Hello guys, this is Al. Today I want to talk about a little bit treatment planning. Therefore, one of the treatment planning, the type of the treatment planning we do is the 3D versus the IMRT, or forward planning versus the IMRT. Basically, when three-dimensional or conformal radiation therapy, we prescribe the dose and then put the geometry of the beam, and if you wanted to put also wedge or any accessories of the treatment planning, then the conformal radiation therapy, basically the algorithm, which could be pencil beam or collapse beam, which is different from Monte Carlo, calculate for you the dose, which basically different from IMRT. Therefore, IMRT, you wanted actually to give, you know what you wanted in your head, that how you wanted to be dose distribution. Therefore, you give all of the constraint to the algorithm, which is the Monte Carlo, and then what it does, the algorithm actually calculate for you how the field size should be, how many the MLC should move to actually give you that dose distribution that is in your head and you want it for your treatment. Therefore, if you look at it, the difference, we'll see that in the three-dimensional radiation therapy, we have very uniform dose and very steady kind of fluence, and in IMRT exactly is different. You don't have this uniformity and you basically get a very high gradient fluence from your algorithm, which depends on the methods that actually the doctor also prescribe for the patient, and also is the patient is a palliative treatment or not palliative treatment, or exactly is treated, the patient is going to be treated, which we call it in the clinic definitive treatment. Therefore, definitive versus the palliative treatment is what we want from those calculation that we can use the 3D or IMRT. For the 3D dimensional, basically used in many cases for palliative treatment, but one specific one that I wanted to talk a little bit is about the breast. For breast, we use the 3D conformal radiation therapy, which basically we have 2 to 5 fields of treatment for radiation of the breast. Therefore, if you wanted to have whole breast radiation therapy, or BRT, basically what we want for the 2 field, we wanted 2 tangent field that comes from 180 degree, which depends on also how you wanted to actually save organ at risk, like lung and heart. If we do the deep breath hold for the patient, or DBIH, basically what we do with the inhale that the patient gets, there should be a gap between the breast and the heart of the patient, because heart is one of the very important organ at risk, and one of those dosimetric metrics that we wanted to meet when we wanted to have the patient go under the radiation therapy for whole breast. Therefore, if we have a 2 breast, 2 tangential for the breast, that is one scenario. And sometimes we have 3 fields, which is 2 tangential that comes from to side, had a 180 degree difference, and also a superclav. Therefore, you wanted to, your patient also get the superclav because of the nodes. Therefore, this is the 3 field. And the forefield is, which we call it anterior, forefield is beside of this, you have an anterior also field. And the fifth field, if we have all of them, we have internal mammary nodes for the patient. If it's involved, we can have the fifth field, which basically for those we actually use the electron. But in general, we use 6 MV for breast when we wanted to 6 MV photon for the breast. And then for the electron 10 to 16 MeV, we can use it for the electron therapy. Therefore, you will see that basically what is important is when you have, for example, for the 2 tangent, you wanted to give to the breast of the patients, you definitely wanted to make sure that the heart, when you wanted to conform the dose or the MLCs, exactly you completely can cover the heart of the patients, which is super important. And the isocenter that we use usually for the dose calculation is 1/3 of the thickness of the breast from top to where meets the rib cage. Therefore, basically we can say in practice is like a 1.5 to 2 cm from the rib cage is going to be the isocenter that you wanted to calculate your dose for the breast. And when you wanted to, before you wanted to dose the calculation, you wanted to have the flash, which basically if you're looking at the left breast, you wanted to give no superior for the flash, 1 and 2 to 2 centimeter inferior and 2 centimeter lateral, you want to give the flash. Why you wanted to give the flash? The reason that we do the flash for the breast is basically is the breast motion during the treatment, and also when you give the treatment to the patient, the breast of the patient swollen, therefore you wanted to also consider that factor to your treatment. That's why you give always 2 cm flash in the 3 edge that I told you. And also it's super important that we wanted to also give as much as possible less long dose and the hard dose to the patients. Therefore, those are 2 metrics that we wanted to give, beside also give low dose to the areola, which is very sensitive to the radiation. And I wanted to end this video here. Please subscribe for the channel, and thank you for watching my videos, and have a wonderful day, and see you soon.